Welcome to the Arguments in the Field Diet Modifications debate by Abby, Allison, Justine, Emmy, and Nicole. To begin, we're going to review on what diet modifications are. These are changes typically made by healthcare providers for a variety of reasons, including patient safety, health-related problems that can be chronic or acute, age-related changes, and a need for increased nutrients. These modifications may be sustained or temporary, depending on the case. In relation to SLP recommendations for diet modifications, we are talking about dysphagia. We will be debating if these modifications create a safer swallow for an individual who has or is at risk for dysphagia through discussing the pros and cons.
To further our introduction, I'm going to start by talking about the National Dysphagia Diet, otherwise known as the NDD. This was developed as a consensus by dietitians, SLPs, and food scientists. There are 4 levels of semi-solid foods and 4 levels of liquids based on different textural properties. The first 4 levels of semi-solid foods include level 1 as pureed foods like pureed fruit, level 2 as mechanically altered foods like ground meat, level 3 as advanced foods, you can think of cooked pasta, and level 4 are regular foods where all food consistencies are allowed. The next 4 levels are the levels of liquids. We have thin liquids like water and tea, nectar-thick liquids, think of a tomato juice consistency, honey-thick liquids like honey, and pudding-thick liquids like pudding consistencies. In 2021, the National Dysphagia Diet was replaced by the International Dysphagia Diet Standardization Initiative, otherwise known as IDDSI. Depending on which hospital you are in, you may see one of these standards used. Some hospitals have fully transitioned to IDDSI, and some still use the NDD framework. The IDDSI framework consists of a continuum of 8 levels, from 0 to 7. Drinks or liquids are measured from levels 0 to 4, and they include thin, slightly thick, mildly thick, moderately thick, and extremely thick liquids, and foods are measured from levels 3 to 7, and these include liquidized, pureed, minced and moist, soft and bite-sized, easy to chew, and regular foods. This framework provides a common terminology to describe both textures and food thicknesses.
Abby and Allison are now going to present to you, the jury, the pros of diet modifications. To begin the pro side, we want to validate the reality that diet modifications often do limit a patient's selection of food and drink choices. Our opposing side is going to give you a whole lot of evidence about it, and we get it. That is why patients have the option to say no to our diet recommendations. But the fact is that based on extensive research, which we are going to highlight throughout our presentation, diet modifications substantially reduce the risk of aspiration. Research shows that reducing this risk enables patients to have a higher chance of living a longer and healthier life. Take age-related frailty, for example. Reductions in muscle mass and strength are well-known complications of advancing age. All muscles in the body are affected, including those critical to chewing and swallowing. A study conducted in 2018 found that age-related frail patients who adhere to recommendations of modified food textures have significantly reduced choking and aspiration instances, while all maintaining sufficient oral intake in comparison to a control group. By maximizing safe oral intake to maintain adequate nutrition and general health, age-related frail patients will have a higher chance of living a longer and healthier life.
Our next pro involves patients who have been recently extubated. Diet modifications are vital during the acute stages post-extubation. Many individuals who have recently been extubated experience post-extubation dysphagia. This is defined as the difficulty or inability to effectively and safely transfer food and liquid from the mouth to the stomach after extubation. In one article we found, it stated that aspiration is present in more than 40% of medical, surgical, and cardiac patients post-extubation. As we know, endotracheal intubation has an effect on the swallow due to the muscles and structures that it touches and surrounds. Patients may experience laryngeal trauma with edema of many structures, muscle weakness and atrophy of the vocal folds due to the endotracheal tube sitting in between, and the coordination in between respiration and swallowing may be delayed. While this is important, it is just as important to know that these are oftentimes just temporarily weakened. Think about this. When someone breaks their leg, they aren't going to automatically walk the next day. They're going to get a cast, which is a temporary fix, before beginning to walk again. Same thing with our swallow. Post-extubation requires a temporary fix of a modified diet due to the muscle weakness, allowing patients time to strengthen muscles again. SLPs choose to reduce the risk of aspiration through using a modified diet to alter the transport or flow of foods and liquids to facilitate a safer swallow. Research shows that thickening liquids increases their viscosity, thus reducing flow velocity and potentially decreasing penetration aspiration risk in all patients. At the end of the day, the biggest goal we found in all of our research is not to keep the patient on a modified diet forever, but to resume a safe, normal oral diet as soon as possible.
The next point we are going to make is about patients in acute stages of care, meaning patients who have had conditions that are severe and sudden in onset. They are in a state of frailty. They typically do not have the baseline level of strength and therefore may not be able to have the ability to eat the foods that they usually do without aspirating. Diet modifications are beneficial for these patients because they compensate for the impairment in swallow function by choosing the best possible viscosity to ensure safe oral intake while still allowing for adequate nutrition. Take an acute stroke patient, for example. The early management of swallowing in stroke patients is essential to decrease the further risk of complications. One study found that the use of spoon-thick consistencies significantly reduced the risk of aspiration compared to liquid consistencies in acute phase stroke patients. Similar findings from a study regarding acute brain disorders at large indicate that textured modified foods were found to be beneficial for patients with dysphagia and various acute brain disorders. The thickness and texture allowed for a safer swallow. These studies concluded that there is a need to manipulate thickness in management of dysphagia in acute stroke patients and patients with acute brain injuries at large. They also may serve as a warning regarding the greater risk of aspiration with liquids in acute stroke patients and brain-injured patients.
Okay, so next we're going to talk about the cons of diet modification, and this was done by Emmy, Nicole, and Justine. So the first con that we're going to be talking about today is follow-through, and this has to do with the nurse's education on dysphagia and the consultation with SLPs, and also the variability in the creation of these modified liquids. So research shows that the nurse education on dysphagia and consultation with SLPs can be minimal, and also that there is variability in the creation of these liquids. So one of the journals we found talked about how nurses, their education on dysphagia, one stat said 4.44% felt that they had sufficient formal education, and 18.60% felt they had dysphagia related on-the-job training in the past 12 months. And one shocking stat I found said 94.8% have encountered a practice by nurses citing permission to downgrade dysphagia diets without the consultation of SLPs. And as we know, dysphagia diets are within the scope of practice of SLPs, so it would be very beneficial to consult with them. And then as for the creation of modified liquids, there's lots of different groups involved, and maybe they don't all have the same level of training or proper amount of training, and this can just lead to variability in the creation of these liquids. Also, the National Dysphagia Diet and the National Dysphagia Diet Task Force had created some standards for texture modifications, which is good. We need some standardization. But one thing is they don't have information about differences for liquids. For example, water from soda. Those are obviously different textures, and when they are modified, they can be different. And all this can lead to labels and instructions seeming too vague. And unfortunately, this could all lead to the patient receiving the incorrect amount or the incorrect modified liquid, which can unfortunately increase the risk of them being at risk for aspiration or feeling dehydrated.
The second con would be variability. Through research, there is shown to be substantial variability in terminology and standards for modified diets, and this goes for both the recommendations of individual SLPs as well as in the consistencies of diets prepared by healthcare staff. Like we talked about before with improper training to nurses or that there's not enough training to caregivers, but there's also this inconsistency that we see within SLPs themselves that's worth talking about. Throughout the literature, seeing this great variability in the consistencies of thickened liquids prepared by staff within and between hospitals, how can we not expect that the same problems are not translating with in-house production of modified texture foods and liquids? Even experienced SLPs have been unable to reliably and consistently replicate liquids to desired levels to patients. And there's also been this inconsistency of treatment approaches that we see. We saw that among experienced SLPs, prescribed consistencies and responses to patients have ranged from 5% to greater than 90% in differences, and many patients have been seen to be placed on an overly restrictive diet, especially within nursing homes. Con 3 would be economic costs and cultural differences that we see within diet modifications. Through research, scarcity coupled with the responsibility of needing to manage dysphagia at home creates tension, it creates caregiver burnout, as well as a lack of compliance. In the USA, the total monthly cost for thickened liquids for a person has been estimated to be in the range of $174 to $289. With that cost and the use of this technique, it can become increasingly difficult because of resource scarcity or contextual constraints such as a lack of access to running water or needed kitchen items such as a kettle or a blender. There's also been this lack of research proving modified diets even reduce pneumonia. So the cost from now consequences of modified diets, such as treating dehydration or providing nutritional supplements, would also be equally deserving to be considered during an economic analysis of cost. When we look at culture, research showed that 71% of participants and their caregivers experiences challenges on different cultural views regarding the management of dysphagia. With food, there's differences within ingredients, methods of preparation, and types of food eaten at different meals vary greatly among cultures, which could become a barrier for this type of treatment.
Our next con is con 4, which is quality of life, food refusal, and end-of-life care. Through my research, there has been shown that quality of life, food refusal, and end-of-life care is a detrimental part of why diet modifications aren't always the best choice in treatment. It is the SLP's job to recommend a course of treatment, but it's essential to listen to what the client truly wants and what will provide them with the most comfort. There are two types of quality of life. There's health-related quality of life and dysphagia quality of life. Quality of life, abbreviated, is QOL. So health-related quality of life is a multidimensional concept that considers physical, mental, emotional, and social functioning of the client. And dysphagia quality of life refers to how swallowing impairments affect the patient's overall well-being and ability to participate within their social environment. This can affect self-esteem, socialization, and enjoyment of life. Food refusal. The main reason for food refusal is no longer wanting food. This is a characteristic of unnecessary and additional suffering, as a cause for accelerated dying and the induction of premature death. Refusing to eat and drink corresponds to the need for autonomy at the end of life, and can be considered as the patient's last opportunity to express his or her will. To continue with con 4, I'm going to discuss end-of-life care. So once a patient has a documented palliative treatment plan, so palliative also means end-of-life care, SLPs may legally and actively prescribe food and fluids that may be aspirated, as the goal of treatment is now comfort and pleasure versus longevity. So it's very important to provide our client with the utmost comfort and the utmost care and make sure they're content with the situation they're in versus longevity, meaning extending their life for a longer period of time, which in case they may be suffering, which is not good. An SLP has ethical responsibilities to facilitate informed decision-making based upon clear communication regarding options, risks, and likely consequences of dysphagia management. So as an SLP, it's very important to have constant communication between the client and the client's family, we want to make sure we cover all the bases when figuring out the best way to manage their dysphagia and come up with a treatment plan that specifically works for that specific client. When doing research on end-of-life care, I found a case study involving a woman with advanced dementia. So this case study illustrates the potential role of an SLP in improving quality of end-of-life care with people with advanced dementia. And in this particular case, Molly is an 85-year-old living in a residential care facility. She works with an SLP as her communication and swallowing needs increase, and Molly has become increasingly frail and less interested in eating. Molly's daughter thanked the SLP, and 12 months later, she began eating very little of her modified diet and fluids. Her daughter received a call that Molly had pneumonia, and the daughter requested Molly, who's her mom, to be transferred from the hospital and expressed a preference for a palliative care approach. The residential place that Molly was living in provided her with that service and ensured her comfort. Molly then passed away 48 hours later. The SLP's approach was to recommend a course of treatment and then to proceed to focus on the client's and client's family's wishes, which in this case involved focusing on comfort and pain management. This case just proves the clear communication between the patient's family, and the SLP, and how crucial it is to be respectful of your client's wishes and provide them with the utmost care.
Con 5 would be the safety issue that we've been talking about throughout the slides, that the use of modified diets contribute to the high prevalence of poor hydration and malnutrition in those with dysphagia. Poor hydration is common in frail individuals, particularly in nursing home residents, where up to a half of residents in several studies have current or impeding water loss dehydration due to dysphagia. Literature found that the greatest contribution to oral fluid intake in hospital patients with dysphagia was from food rather than beverages. Even allowing for this, none of the patients in their studies achieved their calculated fluid requirements. Looking at malnutrition, the use of modified diets, specifically pureed diets, contribute to the high prevalence of malnutrition in those with dysphagia, especially in long-term care residents. A reduction in food intake is also common, and pureed diets are often poorer in calories, protein, and micronutrients than regular diets. So this is a great challenge, especially when working with frail patients as we do.
To continue with what Nicole was saying on the previous slide about safety, with a lack of supporting evidence that diet modifications prevent aspiration and pneumonia, this treatment method is used in everyday practice, especially with frail individuals. However, thickened liquids have shown to delay medication absorption. So within delayed medication absorption, even a minimal increase in viscosity, which is thickness, can delay medication absorption. Therefore, drugs may be specifically affected if given with thickened liquids. There is a lack of research and evidence supporting the use of modified diets to reduce pneumonia, which has been widely acknowledged in the dysphagia literature. Several writers have expressed unease about how widely they use diet modifications in everyday practice despite the lack of evidence.
You just heard some good arguments from the opposing side, and like we said at the start of this presentation, we get it. We get that there is an economic burden associated with diet modifications, but there's usually an economic burden associated with any form of medical treatment. As SLPs, that's why we need to be aware of the financial resources that are available and learn to advocate for our patients as much as we can. We get that the quality of life will be impacted, but that at the end of the day, we have to recommend what is medically best for our patients. While that means that they may not have the ability to indulge in their favorite foods, it does mean that they will have a higher chance of safe oral intake, which will benefit their general health and safety.
Lastly, we want to follow up the quote-unquote follow-through argument that the con group made about the lack of proper implementation and training of medical professionals. When all medical professionals are educated on the effects and proper implementation of diet modifications, patients are most likely to benefit. By implementing medical staff training and education on diet modifications, research shows that there is significant improvement in mealtime compliance of staff, meaning that staff are more likely to comply with the recommendations provided from SLPs for individuals' diets. Following implementation of the International Dysphagia Diet Standardization Initiative across 5 aged care facilities, resulted in proper diet modification compliance and increased staff knowledge, which remained at 6 months post-intervention.
So, based on the evidence presented by the pro side, we know modified diets may benefit those who we are trying to reduce the risk of aspiration. If they maybe just had an acute stroke or acute brain injury, these modified diets might help them get the nutrition they need. Same with recently being extubated, because we know they may be feeling weak. And at the end of the day, the goal is to only keep them on this diet temporarily. It's not something SLPs put them on forever. Instead, it should act as like a temporary fix while they regain strength. And then based on the evidence presented by the cons side, they may not benefit those who refuse food, certain safety concerns like hydration, palliative care, those with poor socioeconomic status, or for nurses who maybe haven't had enough training or education on dysphagia. It's important to listen to what the patient wants and is comfortable with. There are pros and cons to diet modification, but SLPs who consider all these factors, including the pros, are that diet modifications allow for safer oral intake, but also the cons, which include that the patient may not want to follow these recommendations because of things like not being able to indulge in the foods they like. The SLP should make diet modification recommendations that take all of this into account in hopes of the best possible outcome for the patient.
Thank you all for listening. We hope that you, the jury, will make the right decision, which is the pros of diet modifications, obviously. Just kidding, kind of.